Hello guys, welcome back. This is Dr. Anjit and we are going to start a series on PYTs, the most important previous year topics which has come in the NEET PG, FMG and INST exam. And here in this video, we're going to read about amyloidosis. There'll be a clutter-free thing. I'll keep it as minimal as possible. The final things what you have to remember before going to the exam is what we're going to discuss. Amyloid, it was thought as a starch or amylin-like, so we gave the name, but later we found out it is not starch, it is nothing but a fibrillar protein. It's a fibril, right? So what is actually amyloid? Is a malformed protein. So amyloid is made of a non-branching beta-pleated sheets. That's why it's like this, fibril. It's a fibrillar protein, right? A non-branching beta-pleated sheets of size of 7.5 to 10 nanometer size. That's the size of amyloid of each sheet. This is constituting 95% of amyloid. Rest 5% of them, we have few other proteins and a protein P component called as glycoprotein and few other proteins, right? The predominant of the amyloid is going to be 95% made of non-branching fibrils of beta-pleated sheets. It's a misformed or a malformed protein, that's all, right? So there are multiple different types of amyloid. Every amyloid protein will have an A in the front. AL stands for amyloid light chain. AA stands for amyloid A protein. ACal stands for amyloid calcitonin, right? So we generally divide amyloid based on the location as generalized, based on the origin as hereditary, or again based on the location localized, right? This is how Robbins divides, and we'll go with the same thing. In case of a multiple myeloma, this is undoubtedly one of the most common cause of amyloidosis. There'll be lots and lots of immunoglobulin produced, and its breakdown product light chain kind of deposits in and around the body. So we have AL amyloidosis. That's one. Okay. Then chronic inflammation. We had read about a protein called as serum amyloid A protein, which is an acute phase reactant. So when you have fever, serum amyloid A protein will be elevated. Let's assume you have fever for the next 1 year. Next 1 year, serum amyloid A protein will be elevated and it will obviously get deposited in the form of AA amyloidosis. So any chronic inflammation which lasts for a longer time will result in AA amyloidosis, right? So this is an rheumatoid arthritis is one of the commonest cause. Tuberculosis, as you know, is definitely chronic, which can also cause an AA amyloidosis, right? Let's come to chronic hemodialysis induced. Hemodialysis has there's a molecule in my body called beta-2 microglobulin, which comes from MHC complexes. So when I do a chronic hemodialysis, this is less filtered compared to the rest of the proteins because dialysis machine, though they are amazing, they cannot be as perfect. So over the period of years, when a person is on chronic hemodialysis, the beta-2 microglobulin keeps on storing a little bit more and more and more, and results in a beta-2 amyloidosis. This is a very important PYT, has been asked multiple times. And a unique thing, remember this maybe for future questions. A beta amyloid gets deposited in the joints and soft tissue. Who knows? You might get an answer in the next INST coming on that. Fine. Okay, the next. So next is familial Mediterranean fever. These are hereditary causes. I have two hereditary causes. In this disease, I have a mutation in a protein called spirin. As the name says, spirin causes fever by increasing interleukin 1. Just now we read that whenever you have fever or any inflammation, I'll have more amount of serum amyloid A protein, right? That obviously going to result in same AA amyloid. This also causes AA amyloid. This also causes AA amyloid, right? The only difference is this having a chronic inflammation. This is a mutation related pyrin gene. Again, Mediterranean fever. That's all. We have something called familial amyloidotic polyneuropathy. So in this condition, there's a protein called as transthyretin that gets mutated. Because of the mutation, my body is not able to destroy them. If I'm not able to destroy them, automatically more and more and more accumulates, and I'm going to have ATTR, amyloid transthyretin deposit. This amyloid transthyretin can also be seen in one more cases called as senile systemic amyloidosis. Please be very, very careful. If the question asks a normal transthyretin, then it's senile systemic amyloidosis. If the question is going to ask a mutated transthyretin, then it's your familial amyloidotic polyneuropathy. What happens here is, let's assume it's a 95, 100-year-old person, very old, not able to even metabolize normal transthyretin. That's why it accumulates. But here I'm having a protein which is resisting the proteolysis or destruction that accumulates. Fine. Okay, then localized. Very simple ones. In brain, that's your Alzheimer's disease, that's senile cerebral amyloidosis. We have a protein called an amyloid precursor protein, which is there in the lots of neurons. So breakdown product of amyloid precursor protein is A beta. That gets accumulated abnormally, resulting in A beta amyloidosis, fine? Or A beta 42 is more specific if you want to learn about it. One more important PYQ here. This amyloid precursor protein is in chromosome 21. That's why you must have read that Down syndrome is an increased risk of Alzheimer's disease. Down syndrome 321, more amyloid precursor protein, more A beta obviously can result in Alzheimer's disease, right? Perfect. Medullary carcinoma thyroid coming from parafollicular cells, more calcitonin, ACal. Diabetes Type 2 diabetes, there's lots and lots of insulin, only in type 2. In type 1, it'll be the opposite. When more insulin is produced, the breakdown product C peptide will be there. One of the peptide will be getting deposited whenever there's an overproduction of insulin, resulting in islet amyloid polypeptide. This is a type of localized amyloidosis seen only in pancreas, right? There's one more thing also, isolated atrial amyloidosis. Atrial amyloidosis, I have lots and lots of your atrial natriuretic factor or atrial natriuretic protein, which can be deposited, mostly seen in chronic case of congestive cardiac failure, fine. So these are the different types of amyloid. That's done. How do I diagnose? The most common organ affected is kidney. Death due to amyloidosis generally is due to your heart failure, right? That's the one thing which I want you to remember. Most common undoubtedly is the renal, which will be the most common affected organ, and death due to amyloidosis is generally due to cardiac, because I don't have any treatment for amyloidosis. Kidney, if it fails, can take care. Heart, if it fails, is very difficult to go for a cardiac transplant, right? Let's say you suspect a case of amyloid. So what do I do? If it's an renal amyloidosis, take the biopsy of that particular organ. If I don't know, suspecting generally amyloidosis, take any biopsy of a vessel-rich structure, because amyloid always deposits in the perivascular space. That's why it's important, right? That's why abdomen fat part is preferred. There must be multiple places you must have read rectal biopsy. Yes, it also has more vessels, hemorrhoids, vessels, right? Ideally is vessel. Tell me which is easier, abdomen fat part or put a proctoscopy and take a rectal biopsy. Obviously, fat part is much easier, right? That's why it's preferred site. There's no advantage or no difference in sensitivity or specificity, because both of them are going to do the same test, biopsy, fine. So when you take an abdominal fat part, in the microscopy, amyloid looks completely pink in color. It's a protein. Every protein will be pink in color. Same, we have a problem. If many things are pink in color, I don't know what is it a protein, or is it an amyloid, is it a glycogen? I don't know, right? So go for a stain. There are multiple stains, thioflavin, iodine, crystal violet. There is lots and lots of stains, not required. The only stain which you want you to remember is congruent. Congruent will stain amyloid, and then if I look at a normal microscopy, it will have a kind of an orangish color called salmon pink. It looks like salmon fish's flesh, pinkish orange color. That's a salmon pink color in light microscopy. So how does congruent give a color is this, what the beta pleated sheets of amyloid is. That's why we read non-branching. Congruent goes and attaches in between. It makes them kind of branch. So that connection is what congruent does. And when I put a polarized light, do it. It's light being shined at a branch, right? So it reflects. So when I use a congruent microscopy under a polarized light, that gives a beautiful apple green birefringence. The classical apple green birefringence for amyloid, right? So that's all in short about amyloid. We'll try to do it one every day if possible, maybe more. Tell me which topics you want next. We'll definitely discuss that. We'll make sure before your NEET PG exam, we'll cover all the important PYQs here, right? See you soon. Till then, bye bye from Dr. Ajit. Bye bye.